Hi everyone, my name's Rachel Moses. I'm a consultant respiratory physiotherapist. I'm in a chief HP role at the moment, and you guys are all watching or listening to the COVID ICU recovery podcast. And I am delighted to be here this evening on this Friday evening with some incredible speakers who have agreed to put themselves forward to talk about lived experiences of their journey so far as part of the COVID-19 pandemic and what they're doing and how they're helping and supporting ICU patients in each of their trusts. So I'm going to introduce each of the speakers. So to my left, to my top left is Kate Tantum, who is a specialist sister in intensive care recovery and rehabilitation at the University Hospital of Plymouth. And next to my top right is Penny, who is a specialist clinical lead occupational therapist in critical care at King's College Hospitals. Then to my bottom left is Sarah Wallace, who is a consultant speech and language therapist based at Wythenshawe Hospital, part of the Manchester University Foundation Trust. And she is also the National Tracheostomy Safety Project SLT lead and chair of the Royal College of Speech and Language Therapy Tracheostomy Specialist Interest Group. And last but by no means least, for those of you that don't know, Danni the dietitian. She is principal critical care dietitian at Guy's and St Thomas's Hospital in London, and she is a national advisor for all things dietetics. So this is the elite of the elite here I'm speaking to, and I'm super grateful. Everything we're going to talk about is just clinical experience. It is not by any means saying it's the only way to do it or the best way to do it. And these guys have put themselves open to criticism and critique, so we're really grateful that they're here today to share their experiences. And today we're going to be talking about the MDT involvement for post-recovery ICU patients. So what happens when someone is unwell enough with COVID-19 to need admission into critical care and intubation? And obviously the very first part of being on a ventilator is the intubation itself. And what we're finding with COVID patients is sometimes there can be a delay to intubation. Sometimes patients just aren't intubated once. They might have one or multiple tube changes because we're having problems with blocked airways. So the humidification systems are different. And we're actually seeing in the UK a phenotype of patient that have airway injuries and edema, and that's complicating the recovery process. So I'm going to come first to Sarah Wallace, who is without a doubt an expert in this field. And I just want you to talk a little bit, Sarah, about your experience and your colleagues' experiences of airway problems.
Yeah, thank you very much, Rachel, and thanks for having me on the podcast. So there are a lot of issues around airway with this disease, and clinicians are seeing some worrying signs quite early on. Some of this is because of the prolonged intubation, as you say, and re-intubation, and some of it is actually due to COVID itself. So I think there's definitely some signs of laryngeal injury from the airway, patients being intubated for prolonged periods of time, sometimes 3 to 4 weeks, being proned. You know, this is a very delicate laryngotracheal anatomy with a large ET tube in there over a long period of time. So it causes injury. We already know this, but in COVID patients, we're also seeing other issues such as laryngeal edema and inflammation, ulceration, and we think this is actually part of COVID itself. Even people with mild COVID disease get laryngitis issues and hoarseness. So there's mucosal injury as well, and it's contributing to increased failed extubation and quite high failed extubation rates in these patients, with stridor being a significant issue. And I think is also creating an increased need for tracheostomy in some patients. And one of the problems we've had is that we've not been using endoscopy, so it's been difficult sometimes to judge if a patient has got an edema issue until you take the tube out and then they fail extubation. So I think those are the sort of problems that are apparent really early on. But one of the other issues is our concern about stenosis, which is something that develops over time, and we may even see presenting 3 to 4 months later on, as a result again of having an ET tube in for a long period of time. And I think we're going to have a group of patients who require ongoing specialist airway clinics, perhaps joint SLT, respiratory and ENT intervention, because they present with later onset glottic, subglottic and tracheal stenosis issues, which is going to show itself in things like breathlessness and all of the anxiety that goes along with that. And potentially all that scarring that's going to develop over time as a result of intubation is an issue. And with that, you're going to have problems with voice and swallowing as well.
Yeah, that's all fascinating. And I just remember back when we were first planning COVID in this country, and as therapists, and we were told, by our colleagues that tracheostomies wouldn't be needed, they're intubated for a short period of time. And we didn't plan for trachees in this patient group, but we're told it was never going to be safe and we were never going to need them. So in now nationally, tracheostomies are an accepted intervention for these patients, and we know in terms of some centres are doing them earlier, so maybe even within the first week, the first 7 days. Some centres are still leaving it, as like you said, too much later, to like week 2 or even week 3. So with regards to tracheostomies come added challenges, don't there, for us as therapists? So do you just want to talk a little bit about what we can and we can't do, or what is good practice?
Yeah, I mean, it's turned tracheostomy weaning on its head, COVID. As we all know, there's so many concerns about virus transmission with every single thing you do with tracheostomy, routine care and management and weaning. And, the thing that I've been banging on about for years as a speech and language therapist is early cuff deflation. And obviously with coronavirus, there's been a lot of concerns about letting the cuff down, increasing aerosol generation. So one of the biggest challenges with tracheostomy has been around timing, as you say. So what's the right time to do a tracheostomy? And I think we've seen a trend for it to become earlier, as you say. It started out that sometimes they were waiting 3 weeks or so, and then it's now they'll tracheostomize a patient who's still COVID positive. And there were all those issues around, is it safe to do it? And should ENT do it? And, all the PPE aspects about that. But I think in terms of routine care and management, there's several challenges. One is about releasing airflow into the upper airway and generating aerosols. So we've had patients who've had prolonged cuff inflation, leaving cuff deflation almost to the very end as a sort of almost a decannulation test. So with that, we have prolonged voicelessness, patients can't communicate, and all of the anxiety issues and psychological issues that go with that. Delirium issues, and again, the sort of increased problems with communication that come with that. And I think we can't use above confocalization because we're worried about airway patency. We can't do endoscopy. We haven't been able to do, things like fees and just all of the whole aspects around communication. And the other thing I think is that we've had teams who are not so familiar with managing tracheostomy, so staff who have been brought into ICU. My very first tracheostomy patient I went to see weeks ago, the nurse said to me, I've never seen a tracheostomy before and I'm managing this patient. So it's really become important that we work as a team to support each other around how we manage keeping a circuit closed, how we do suctioning, how we manage that wean. And I think the main thing for me has been helping everyone with communication support for a patient. And that's been the whole team's job, giving people the right resources so they can provide charts or just those basic communication resources to help everybody around that phase where a patient can't communicate.
Yeah, absolutely. And even more challenging when the staff are in PPE as well and we haven't got that normal recognition. That's great. Thanks, Sarah. So Moving on to Danni. So these patients are sick. They're really sick. And we know that these patients have, you know, to get to the point they need intensive care treatment, have been sick for a while, normally on average 7 to 10 days, and not feeling well, maybe not eating as well. So then they arrive on ICU, and then, you know, they get intubated and they may be proned, and we have those challenges. So do you want to talk to us a little bit about how we can manage to meet the nutritional needs of these patients and what challenges that you've been seeing?
Yeah, thank you. You really hit the nail on the head there with the lead up to ICU, because I think this part has been a little bit forgotten. Well, certainly was forgotten initially, because obviously in the issues with PPE initially on a lot of intensive care units, dietitians were actually asked to not go onto the unit in a lot of ICUs because they wanted to save PPE for doctors and nurses, which is absolutely the right thing to do. But I then think that there was a lot of missed opportunity to really enhance the nutritional aspect of these patients early on in the ICU, because one of the main symptoms of COVID-19 is obviously taste changes, loss of smell, and also poor appetite. And they have that maybe for a week or maybe longer before they even get into the ICU. So the patients come into intensive care nutritionally compromised anyway. They're then incredibly sick on very, very high doses of sedation and very high doses of paralysis, being proned. All of those aspects interfere with delivery of nutrition. So for various reasons, one, because feeds might be stopped for pre and post proning for a period of time. And then to Sarah's point, where there's new staff who are working on these units, quite frequently we might see those feeds being forgotten to be put back on again. So there's a lot of missed feed. The sedation that was used, mostly being propofol, contains a lot of calories, which a lot of people don't know. So some of these patients were on up to 700 or 800 calories just from propofol, which means that you have to reduce the amount of calories they get from their enteral feed, which inevitably reduces the amount of protein they get. So then that contributes to how much muscle wasting the patients have further on down the track. Because they were so heavily sedated and paralyzed for not just a couple of days, for sometimes weeks in these patients, nothing in the GI tract is moving. So we see a lot of constipation, which then kind of backs things up. We see a lot of high gastric residual volumes and poorly tolerated feed, which again impacts on delivery of nutrition. So throughout the intensive care stay, the patients have come in nutritionally compromised, and then perhaps not being able to meet their protein targets, for example, for quite a few days of that admission, has kind of put them really on the back foot in terms of how they can move along with their recovery. On top of that, we've had, as a profession, many other barriers to deal with, one of them being feed shortages. So shortages specifically of the highest protein feeds that we would normally use in the ICU patients, because of the increased need. So because the ICUs were increasing bed capacity 3 or 4-fold, most intensive care units were then significantly increasing the number of, or the amount of feeds that they needed. So that inevitably ran short, like a lot of drugs and other equipment did. So we've been having to try and manage that and work out alternative either feeding regimens to give the patients, or using an additional number of protein supplements compared to what we normally would, to make sure that we can meet protein requirements in this patient group. And so that's kind of the acute side of things that's been a real challenge, I think, from a dietetic point of view.
And I hear from my colleagues that insulin control's been very challenging as well. Do you want to explain what that means a little bit, and how you've been managing that?
Yeah, so blood sugar control has been like nothing I've ever seen before, not in every center and certainly not in every patient, but in a particular group of patients, it has been very difficult to control. So often when patients are very acutely unwell, they do have hyperglycemia anyway, and that is controlled with a sliding scale insulin. And normally that is pretty well controlled. But what we found in these patients is that they've sometimes needed up to 20 or more units of insulin per hour. Normally they might need kind of 3 to 5 units per hour. So this is a huge amount of insulin. And we don't really know what the cause of that is. Part of it is because patients with type 2 diabetes are at higher risk of getting COVID-19. So that was definitely one of the comorbidities, but that certainly doesn't explain all of the reasons for why these patients have these like super high blood sugar levels and significant insulin resistance. So the way we manage that at Guy's and St Thomas's was, or has been in conjunction with the diabetes team. And we have instigated a protocol that the first step is to reduce the carbohydrate dose. In fairness, probably the patients were not on huge amounts of carbohydrates anyway, because we had to reduce the feed because of the propofol. But we look at reducing carbohydrates first and then perhaps changing the insulin regimen in conjunction with the diabetes team. This has caused other problems perhaps down the line, which for people who are listening and maybe having the same issues and looking at patients post ICU, you need to be really careful when the patient steps down from the ICU on really high doses of insulin, because you put the patient at risk of hypoglycemia once they get to the ward, because perhaps the feed hasn't been running during that transfer. Perhaps the ward isn't quite set up yet with a feeding pump to be able to restart the feed. So all of these what we would normally see as very small issues have become really significant issues, because also it's not just ICU staff who are unfamiliar, or staff working in ICU who are unfamiliar with these things. It's also the ward staff who might not be used to patients who are this sick, who are on insulin and who are needing to continue with their nasogastric feeding.
Thanks, Danni. That's super helpful and interesting. And I'm going to move to Kate now, because Danni and Sarah both picked up there on workforce, and you know, to increase ICU capacity, it's not just about machines and equipment and space, is it? It's about the ICU nurse and potentially the non-ICU nurse, especially in the centres that have had to surge their critical care capacity beyond belief. So how has it been for you know, from an ICU nurse perspective? How are you guys managing, you know, with this in terms of your workforce?
I think the workforce challenges have been really significant across the country. We've been quite lucky in our centre. We did upskilling training for a kind of a bed buddy scheme. So we had some simulation training and kind of a core set of 8 competencies that we got people up to speed with quite quickly. And we were incredibly lucky that people came forward with, you know, just such great enthusiasm to be able to support the team. And I think the take-home message is, yes, it's been really hard, but actually everyone has come out of the woodwork to be able to support. I've seen amazing tweets from across the country of random, you know, consultant surgeons being an ICU nurse for a week of nights. And so I think the workforce, it's been very challenging. However, I think the NHS has come to it with real gusto and enthusiasm. So there's been kind of, you know, core training and core safety concerns taken all the time. I think one of the biggest challenges for our nursing colleagues has been the challenges of communicating with families. I think that's been very difficult, and communication generally in these patients, because we obviously get loved ones in nice and early in intensive care, and we can't do that at the moment. So I think everyone's found that quite difficult, and I think it's been really ingenious, the kind of levels of solutions that people have come up with. So rooms papered with photographs of loved ones. And I think also we haven't been using patient diaries probably as much. I don't know, our centre, we stopped our patient diaries because of our red concerns, our COVID concerns. And I think that's been really difficult. So we've been making timelines retrospectively for these patients, which is a hugely time-consuming process, but we know that it's definitely going to help them with their delirium.
So you're touching on the next kind of section a little bit, and it's so these patients who have been really sick, who have been nutritionally compromised, we can't communicate with in the normal way. And we have 2 phenotypes of patient: the patient that isn't weaning particularly well or might have airway issues that needs a tracheostomy, and then we have the patient whose sedation's just suddenly stopped once they're deemed extubatable, and the tube comes out and all of a sudden they're awake in this really scary environment that is ITU normally, but even more so now. You have staff wearing masks and visors and gowns, and like you said, that whole normal ICU environment is even more bizarre and alien to someone who will not probably be able to remember getting ill in the first place. And you've touched on delirium a little bit there, and certainly across the country there is huge reports of delirium for these patients. And you know, with the most experienced ICU staff in the world, they're finding it really challenging. And So do you want to talk a little bit about strategies that, or like what you're seeing with patients and what strategies you might be using to overcome that?
So we know that delirium is, 60 to 80% of normally ventilated patients. And I think probably we haven't got the stats yet, but I think it's going to be significantly increased in this population. And it seems a much more tenacious delirium. That sounds like a funny way of putting it, but it lasts a lot longer and it's a lot harder to kind of tackle. And also I think that's probably due to the levels of acute hypoxia and the levels of sedation that we're using. We're using drugs that we know give nasty deliriums, and I know that benzodiazepines are being used where previously we've probably kind of culturally not used them because we haven't had to. So I think that's all led to this kind of really challenging delirium. I mean, we're doing a lot of kind of non-pharmacological measures to manage delirium, so sleep hygiene, nutrition, pain, all the kind of normal, lovely non-pharmacological stuff that we do. We've been taking patients out into the garden, and we found that to be, really helpful in getting them back into the normal circadian rhythms and making sure they're tired at night and sleeping and awake during the day. And we've actually been quite lucky because we've had a COVID physio team doing as early mobilization as the patient is able to do from a physiological standpoint. And I think so our delirium it's been nasty, but I think the fact that we've been able to put these measures in place, I know that we have had to use more pharmacological measures to manage delirium as well. And it's a really different disease, COVID.
Yeah, I think again you've touched on some other points there around the delirium for patients, but also how the staff might cope with that, and how this cognitive load we have in the intensive care unit is now, as fundamental as ever. So intensive care is a very hostile environment in a lot of ways, and it's a very complex environment for staff. But we have added complexities on these patients, and added factors that maybe present more challenges as well. So delirium's not the only kind of problem we're seeing when these patients are awake and they're extubated, and we maybe don't pick on enough earlier signs of delirium and cognitive impairments. But I'm going to move over to Penny now, and we are finding nationally in this patient group that we are seeing cognitive changes in even young, healthy individuals with no previous history at all. So I'm going to move to Penny to talk a little bit about that. But also first, Penny, I wonder if you could, as an occupational therapist, give us a little synopsis of why on earth we might find an OT in the ICU. Like, people say to us, why do we need you? So first of all, just explain a little bit about why we might find you in the ICU.
Well, occupational therapists look at occupation, which is what you do every day. And actually, we've all had a unique opportunity to see what occupational deprivation is like during lockdown. So when you can't get to do the things you normally do, your well-being is really impacted, and like it can impact on your long-term mental health and your actual normal physical health as well. And that is what happens to our patients in critical care. They are completely restricted from their normal way of life. They've kind of been dragged away from everything that they know. And they're in an environment where they physically can't move, but there's also nothing to do in that environment. It's a very alien environment they haven't been into before. And with COVID, like you said, you've got the PPE as well. So a lot of patients are actually not even aware that COVID arrived in England. And then they wake up in the ICU in this, like something out of a science fiction movie, really. So from an OT point of view, we can help ground people by finding things that they normally would do. And often it is kind of personal care tasks that really help people to kind of feel themselves again. So we can do like little things like combing your hair and things, just making yourself look and feel a bit more normal. And that can really help people to start to feel better and start moving in the right direction towards recovery. Now, during COVID, that's been tricky because normally I get people to bring in their own like hairbrush or toothbrush or whatever, and we haven't been able to do that. They haven't been able to bring in any objects that are familiar to them of anything that they would normally do. So we've had to be a bit more creative about what we're doing with people. And like Kate said, we've had photos of families, but also voice recordings of family so they can hear their voices, and things like very simple puzzles and things that are easy to take into the ICU. And then we have also been doing personal care, but with those terrible tiny combs that do nothing.
So humanizing the ICU, I'm going to be a bit controversial and say what is the point? Does it make people recover quicker? Does it get them out of hospital quicker? Like what's the point? What's the fundamental point?
So they say themselves that when they get into ICU, they don't feel like a human and they don't feel like themselves. So anything that helps them to be able to feel like themselves again is part of their recovery, and is a part of adjusting to what's happened to you, is kind of knowing what you were like before, and then being able to adjust what you're able to do now as you recover to find out what your new identity is. So that's just being able to do things is how people work out what their new identity is. And also just doing things as well helps you physically, cognitively and psychologically. So by doing something, you are rehabbing yourself to help your recovery.
That's great. So that kind of moves us on to the cognition. So we're humanizing the ICU as best we can, and it's PPE and communication impairments and challenges and everything else. So how do we pick up these early cognitive changes or cognitive changes? How do we do that, and what are you seeing in practice at the moment?
So it's a slightly muddied picture because there's a lot of very extreme fatigue and anxiety, and that's always going to impact on your thinking. So what we see in the ICU is not necessarily what will convert into people on the ward and when they go home. But I'm seeing people who are having difficulty with their information processing, so they're needing a bit more time to work out what you're saying to them, and then there'll be a delay before they actually respond to whatever command you've given. They can't focus their attention as well, so you have to kind of keep saying and keep reminding them what you're doing. And in terms of slightly longer term, it's their memory and their executive functions that seem to be something that they're having difficulty with later. So their planning and problem solving and everything that leads them back to being able to get back to life, get back to work, being able to look after the children, those kind of things. So it's quite a complex picture of COVID, and we're also seeing some elements of like disinhibition and impulsivity. It's not a very clear-cut picture, and I think that's related to the hypoxia and the fact it's quite widespread across the brain. And it's something that can last for quite a long time. We know that anyway with people who've had any severe respiratory failure, that they often, when they come back to clinic and things, will still have problems with memory and their executive function and sometimes their attention. So it's something that needs working on really early, and particularly working out strategies to manage it so that they will be able to get back to their everyday lives, even if their cognition hasn't quite caught up by the time that they get home. I think also just education that this is actually quite typical after a critical care stay, and often it can improve, but with COVID we're seeing quite a lot of neurological impairments, so we don't know that it will necessarily improve, but they need to know that this is normal for someone who's in critical care, and that they shouldn't suddenly think they've got dementia or something as well, and it's something that over time can gradually improve. But it's the attention and the information processing is really restricts the rehab, so we're having to do, and the fatigue as well in this, but you're having to do much shorter sessions and really allow them time to do very simple tasks for them to then be able to gradually improve.
I mean, Penny, that's actually fascinating, and I think that is just exemplified why OTs are essential and fundamental in the early stages of any critical illness, really, because I absolutely bet my bottom dollar that there's ICUs up and down the country that just aren't picking up any of this because we don't have the ability, we don't have the clinicians in there looking at this. So fantastic work, and you know, I've learned so much there just listening to you. So these patients have been sick, they've been intubated potentially a long time, potentially have trachees, and they're weaned off the ventilator and they've had the tubes removed. So Sarah, I'm going to come back to you here because we are seeing, like you said, a high incidence of airway injury, airway pathology, and you know, not just voice and swallow problems as well. So do you want to talk a little bit about what we're seeing post extubation in that acute phase?
Yeah, I mean, even in young patients previously fit, they post extubation, they're often, what I'm seeing is complete and utter loss of voice. So they're completely aphonic, and generally the voice problem is resolving, but it's about the laryngeal injury, but it's not just that. It's about what Penny was talking about fatigue, and it's also about respiratory support, breath support behind the voice. So without the breath support, your voice is going to be very weak and quiet. And what happens is that the voice will tire. So along with the fatigue, they may start to get their voice back, but you know, it will fade off at the end of a sentence or become quite weak and quiet. So it's not resolving fully often by discharge home. So what's concerning us is that these patients get follow-up, because they may have residual dysphonias, they then go home, they're just relieved to get home, and we know these patients are getting discharged out of hospital quite quickly once they're onto the ward. But we want to make sure we follow them up. We want to make sure we've got a good triage system in for a GP to pick up this problem later. But we're also keeping these patients on our waiting lists to potentially follow them up with telephone triage or telehealth, and then bring them back to voice clinics, our joint clinics with ENT, to follow up about the dysphonia side of things. But as I say, yeah, even in really young patients, there's ongoing laryngeal symptoms and fatigue in the voice. So it's quite debilitating for patients if they are down the line looking at getting back to work, for example. You know, if they can't actually make themselves heard on the phone, or you know, whatever their vocation is, it can have a significant impact.
And just concentrating on the swallow and the dysphagia part of it, we're heavily reliant, or you guys are heavily reliant on instrumental analysis, and suddenly that's been taken away. So
Yeah.
what's the incidence of dysphagia you're seeing in this patient? Are you seeing any, you know, and how are you managing that?
So I'm quite surprised that this dysphagia is less of an issue than I thought it would be. So we know that a lot of these patients are presenting with a lot of weakness, and usually in ICU, weakness and myopathy causes massive problems with swallowing. 91% of patients with myopathy, critical illness acquired weakness, have a dysphagia. But with coronavirus, what we're not seeing as much weakness in the pharyngeal side of the swallow, pharyngeal phase of the swallow, as I was expecting. But we're seeing problems with the oral phase related to things like tongue weakness, which is again from intubation and the pressure of the ET tube. And if that goes on for weeks, again, there's a lot of problems with tongue weakness, there's problems with oromotor function, and also trauma to the mucosa in the mouth. And the other thing to just say while it's in my head here is about mouth care. So a lot of these patients are really dry, and they're dry, I think, partly from having all the renal problems. They're being dried out as part of their treatment, but also when you're prone, it's quite hard to deliver mouth care effectively. It's physically quite hard to do. So they're very dry, they have high mouth care needs. But again, if you have loss of taste as well, getting someone back to eating and drinking is quite challenging. But with the problems with tongue weakness, we're seeing that with fatigue, again, but general fatigue. It means that patients are needing modified diet and fluids because of the effort of chewing, simply that. But aspiration has not been as big an issue as I think we thought, except for those patients with neurological issues and those patients with ongoing respiratory problems, because you get a problem with timing your breathing and your swallow, and it gets out of sync, and then you're risking inhaling things and aspirating. So it's crucial we manage that problem, because what we don't want is these patients with already very fragile lungs, when we're trying to rehabilitate their pulmonary function, we don't want them aspirating. So it has been a challenge, not having access to fees, which is our go-to assessment in ICU. We've also had problems accessing video fluoroscopy. So when the patients got to the ward and could potentially go to video fluoroscopy, a lot of centres, including my own, we've not been able to send patients who are COVID positive to video fluoroscopy. We've had problems with staffing video fluoroscopy clinics from the radiography side of things because of workforce issues. So we've had a problem getting instrumental assessments. We have, I suppose, managed it by using all the things that we used to do, which are, therapy exercises, compensatory strategies, supporting people to with sort of managing meal times. That has been a challenge though, because of access to PPE and going in to sort of assist patients with feeding. That's a problem. And I think, we have now got a strategy to get back to endoscopy, by the way. We've got a national guideline now with a staged return to that. So that's good news. But I think that fatigue is mainly an issue, and modifying diets has got sort of, even in younger patients. But it's generally, dysphagia has not been as big an issue as dysphonia.
I'm so glad you mentioned mouth care there, because there has been an army of speech and language therapists up and down the country providing mouth care rounds, mouth care routines on critical care, and on respiratory wards, actually, because of the complexities of high flow oxygen, dry oxygen, no humidification, and also communication charts, producing communication charts. And also meal times, like you said. I know 2 or 3 trusts, including the one I previously worked in, where speech and language therapists who weren't doing their normal outpatient activities were on the wards supporting meal times, because these patients were fatigued and they were on oxygen or CPAP, and it was the complexities of managing meals, particularly ones that maybe it wasn't appropriate to get an NG tube in, or they didn't need one, they just needed patience and time. So
I think the challenge with that has been getting access to PPE to go and do that when PPE has been short. There's been a shortage potentially on wards in particular. There's been an issue of, can you go in again to just do that bit of work around mouth care or assistance? But the other thing I wonder if I could just mention is around the patients who have been, who we've seen very severe problems with swallowing, and they're the ones who are frail, who've had coronavirus and probably weren't on intensive care, and we've been doing a lot of making decisions with accepting risk of aspiration, so what we potentially call risk feeding. So that's been quite hard to deal with, and we've not been able to make those decisions in the way we would normally do that, because we wouldn't be able to bring a family in for a best interest meeting. We've got to do things like capacity assessment a different way, but those patients have not done well. They're very frail, very deconditioned, and we've seen their swallowing fall off a cliff, and it's usually irreversible, bordering on palliative. So we've had an increase in work to do around risk feeding, decision making with those patients, which is very sad, actually. But that's the effect of coronavirus on patients who may already have something like dementia or COPD.
And again, I think that's where your unique skill as part of that MDT absolutely comes in, across the whole pathway. So thanks, that's incredible again. So Danni, we've kind of touched a lot on nutrition there, and if we think about the post-extubation phase, so these patients, as you mentioned, may have diabetes, they have severe muscle wastage, they're in this catabolic state, they have maybe higher BMIs, which we're starting to see through the ICNOC data. Huge nutritional challenges. What have you found, and how are you managing them?
Yeah, they are really difficult, and Sarah's touched on quite a few issues actually, and it's really interesting to have the whole MDT here, because I think all of the issues that we see, or the difficulties with these patients, are all intertwined with each other. So actually the MDT working, it is difficult at the moment, obviously, because of the way we work, but it's incredibly important because we can all kind of help each other out quite a lot, I think. So we know that patients post-extubation have still incredibly poor appetite. The taste and the smell changes are continuing post-ICU. So it's not like they get extubated and they wake up and they can suddenly taste again. And actually that is a symptom of ICU anyway. So we know that happens in non-COVID ICU patients too, but it seems to be exacerbated in the COVID patients. As you mentioned, they have significant muscle wasting, which can often be masked by their BMI. So a lot of patients might have a lot of fat mass, which then masks the fact that they've lost a lot of muscle. And a lot of people who don't understand muscle wasting might look at that patient and say, actually, they're all right, they've got enough reserves, but they can't see the fact that they've lost a lot of muscle. They're very weak. They might have these swallowing problems that Sarah's described. They're breathless, they're delirious. So all of those aspects impact on oral intake and then nutritional status going forward. So some work that's been going on at Guy's and St Thomas's has found that patients are actually eating much less than 500 calories per meal. So if you imagine that a patient who is overweight or obese might need 2,000 to 2,500 calories, they're probably getting less than 1,500 calories, probably much less than that in some patients. So they're really, really nutritionally compromised. So one of the common thoughts about post-ICU patients, or any patient really, is that nasogastric feeding interferes with appetite. We know from some work that we've done at Guy's and Tommy's that it actually doesn't at all. So with a post-ICU patient who is NG fed, if you reduce that nasogastric feed or you stop it, that will not magically increase their appetite. They're just not hungry. So we've certainly at our trust now, no nasogastric tube is removed after ICU without review by the dietitian first, because we want to know obviously that they're doing okay. We'll use a lot of nutrition supplements where we can. We similarly have mealtime volunteers who come and help the patients eat normally. That is more difficult during COVID times, but some staff have been redeployed specifically to help with mealtimes for these patients. It's difficult because their family members that would normally bring them food that they like to eat are not able to do that. It's a pretty terrible environment to be eating in. For a while, some hospitals were using paper plates and plastic cutlery. So all of those really small things that kind of, as Penny was talking about, humanize your experience in a hospital were not happening. So it's not a very nice environment to be eating in. So all of those aspects have been kind of interfering with nutritional status. We then get to the post-hospital period when patients get discharged into the community. And this is even more difficult because most of these patients are not on a rehabilitation pathway, and they don't automatically go into a rehabilitation clinic or a follow-up clinic that's specific to their needs. Some hospitals and some centres do have that, but not all of them. So, you know, and a lot of dietitians in the community don't review patients unless they're tube fed. So they wouldn't necessarily see someone who just requires some oral nutrition support. So that's requiring quite a big piece of work at the moment about where we can kind of refer those patients to in the community, because also they're incredibly vulnerable, because if we think about lockdown at the moment, a lot of these patients live by themselves. They can't have family who come and bring them food. We have to send them home with food packages initially, and then work out how actually are they going to be able to get food into their house when they're not strong enough to go out and do the shopping themselves and there's no one to help them. So there's quite a few really complex issues going on that do need a lot of thought and a lot of work. And actually the British Dietetic Association has produced 2 sets of guidance. So one specific for post-ICU patients for some guidance on how to manage nutrition support on the ward and then in the community. And then there is also some guidance for non-ICU patients that really touches on these issues around community referrals and how to manage patients who might be living by themselves as well. So yeah, it's incredibly difficult.
Well, wow. So even that last bit, like, I just had no concept of that. I mean, that is just incredible insight. And as you said, so important, because there is a massive risk of readmission. There's a massive risk of second or concurrent infections or problems. And it's really important. And I think we've got a whole podcast around what happens when people leave ICU and what the path, like in hospital, and what the pathway is going to be, because we just don't know yet, like you said. But having dietitians like you involved who can pick these things up, you know, we can't stress as an MDT how important this is, and how recognised it needs to be. And so, Penny, just listening to what Danny's been saying there about preparing the patient, and everything you said about humanization, and everything you said about occupation. So I suppose for people who don't have access to OT, especially with the skill sets, you know, you have, what kind of things should people be looking out for? What kind of things can they be doing?
It's just working out the person and what matters to them, and how you can get them to be able to access that. So even things like one of the people that I had a daughter who they weren't seeing, and making sure they've got access to be able to either see them or have photos, like I said, or just any kind of activity that they would normally do, anything that can make them feel like themselves again. And speaking to families to find out those kind of things is really important. And what Danny was saying about family, it just made me think that a lot of the help that people need later is they need their family to know what's happened, and they need their family to have an idea of what they're going to come out of hospital like. So it's so important to speak to the family and explain what's happening, and particularly these cognitive elements as well, to explain to them what they might not be able to manage when they get home, and that they need the time, and they need the pacing and the rest to be able to recover. It just, when Danny was saying that, I was like, that's so important, because that's, I think, why sometimes if they do have family at home, that they then are struggling, and they don't have any services when they get home that really suit them necessarily. Other things for in hospital, on the units, I mean, it's just about giving people some kind of normality as well. So having a routine that they can understand. So if you're not eating and you're not doing all the things that you normally do, what routine do you have? So they basically have the nurse's routine or the doctor's routine when they come around and do their ward round, and they don't have their own routine. So it's thinking, what could you put in the day that, oh, okay, at this time we're going to have a wash, or at this time we're going to do this activity, or even we're going to do your orientation board at this set time. It just helps kind of normalize their day, so that they have a bit of a pattern, and it grounds them again, so that they feel like there is something that's supposed to happen at different points of the day, rather than just this monotony and someone coming in and taking their blood pressure or whatever.
And what about sleep for these patients? Are we seeing much sleep disturbance and deprivation? Does that add into the cognition, or? Yeah,
I mean, sleep, as Kate said, is a massive area for delirium, but the environments are really noisy, and particularly we've got units that aren't normally critical care units, and nurses who don't normally work on them, and less nurses than normal. And I've definitely noticed there's a lot more beeping going on, just driving me mad, let alone the patients. So all of the kind of things of making sure that it's dark in when you go to sleep, it's a bit darker and it's a bit quieter, and so you can have sleep at night, so you can be more awake in the day, but also they will sleep more because they're trying to recover. So it's giving them the opportunity to have rest throughout the day, and it's not just physical rest, it's cognitive rest. So if it's really busy, or you're coming and doing obs all the time and you're making them think all the time, then that is not rest. So these patients just don't really get the rest that they need to recover, but we can do as much as we can to make it, you know, face masks and earplugs and things, make it as quiet as possible so that they do get some rest throughout the day and proper sleep at night.
Proper sleep. So moving on to Kate Tantum, the original rehab legend, hashtag herself. So okay, we've spoke about so much. I mean, you are a massive advocate of the MDT as a nurse, as a critical care nurse. So we've talked about the complexities of these patients in terms of the phenotype of the disease and how it presents and manifests, and the complexities in recovery. So what have you been doing? What strategies have you developed that may not be unique to COVID, or maybe? And what advice do you have for people out there?
So we were really lucky. We had a red MDT COVID team who covered all the red wards and all the red ICUs, and that was really good because it allowed us it took us a couple of weeks to get it sorted, but we were able to work really clearly as a team, and we were able to follow the patients from ICU all the way through their journey. So we were ICU, ward and discharge, and actually that was really good because we were able to humanize it from the start. We were able to goal set holistically. We were able to put rehab plans up in ICU, take it through to the ward. I mean, one of just the most amazing experiences for us for COVID was we had a group of 4 who had got very close and were all in at the same time in intensive care, and they were all discharged at the same time. And for their rehab, they were doing circuits in their ward with one of our rehab team, and it was beautiful because we had physio, and we had speech and language, and we had occupational therapy, and then they went out into the garden and played skittles and, you know, played with basketballs. And I think for me, COVID has given the NHS a huge opportunity for a hard reset to look how rehab and recovery is teamwork, and it's rehab legend teamwork, and we need all of us in it. You know, it's a team, and we need all of our skills and everything to just kind of make it work. And I think post-intensive care syndrome probably hasn't been given the kind of notice in outside of ICU that before, and I think COVID has given us all the opportunity nationally to look at our ICU survivor population and post-intensive care syndrome and how difficult and complex it is for them and their families. So I really hope that this is an opportunity to kind of reshape what we do. But all of these stories, like I was so drawn in with all of it. I was concentrating so much on what everyone was saying because it's such a great time. So I think this has just proved that teamwork makes the dream work.
Absolutely. And with any luck, Kate, there might be some commissioners listening out there. There might be some media outlets out there that want to cover this kind of stuff in more depth, because I think if we get the message out there about why we can talk about how great we all are. I mean, sometimes it's about presenting the risk. So if you're sitting there, if you're a commissioner of a service or a manager of an intensive care unit, and you don't have these people in your intensive care unit, you know, that is potentially a risk. Well, it is a risk, let's face it, for your patients in terms of getting best care and the care that they deserve. So what advice, how can we get this ball moving? Like, you know, how can we do that?
I think the best thing to do is so the things that we did is we built our rehab by doing local kind of prevalent stuff to prove that we needed a problem. That's how we got our clinical psychology team. That's how we got our physio team. That's how we've got a specialist nursing team, but we haven't still got all of the MDT input that we need. I think sharing rehab legend stories is really important because it allows all of us to learn from each other, and Twitter and social media can be a great way of learning from each other and kind of learning what works. So I think so I think the best thing to do is to look at all the absolute excellence in your relevant trusts and departments, because it's everywhere. The NHS is an amazing organisation. I think COVID has proved this with bells on, hasn't it? So I think we just have to keep looking for the excellence and supporting people in proving that their service is making a difference to patients with patient stories, with data, because we know that data speaks to commissioners. And we need to have hard research evidence. So we need an evidence base, we need a patient story, and we need the economics. And I think then you stand in a really good stead of getting your service commissioned. But it is a challenge, but I think what you have to do is look to your colleagues and look to rehab legend stories, and you'll see amazing things across the UK every single day.
Absolutely. Hashtag rehab legend.
Hashtag rehab legend.
Hashtag. So, I mean, it's just been so insightful in terms of just trying to round things up, some little notes I've been making about early MDT working in the ICU in that critical care phase. So dietitians from a nutritional perspective, the complexities surrounding that, from procurement to delivery to challenges with proning, positioning, gut motility, delivery of feed, everything. From a SLT perspective, a speech and language perspective, not just about airway, about communication, so to some degree swallow, but around the laryngeal injury, the voice problems and long-term problems we're going to face. OT, cognition, occupation, humanization, the impact on that in terms of recovery, going back to work, getting over post-traumatic stress. I mean, we're in the very early stages of this in the UK, but kind of understanding and identifying that. And then obviously everything from, you've been saying, Kate, in that very post-nurse recovery, roles, changing expectations, changing how we do things. So Sarah, I'm going to come to you first. If there's anything you'd like to add or summarise or share.
It's hard to think of anything beyond what you guys have said already, except it's all about the team, isn't it? I mean, none of us could do our individual jobs without each other. I can think of so many examples of patients I've seen where, so for instance, I saw a patient, one of my first tracheostomy patients, myself and the physio did the joint assessment, and the way that we got better voice was by the physio help. You know, I was helping the physio to stand the patient, and then they got better voice. And you know, it's working together that actually helps us to get a better outcome for a patient. But I also think about what Penny was saying around making our goals patient-led. It has to be about what the patient wants ultimately, and you know, around the sort of cognitive side of things and communication, cognitive deficits. We don't know what's going to happen with that, and we won't know that because patients have gone home to a very strange lockdown situation, and so until they go back to work, we won't know if they're going to have any cognitive communication deficits, you know, when they start trying to do their job again. So it's about the follow-up, the rehab pathway for those who really need it, but also just, as you say, the amazing things that have happened in this period that have basically given us opportunities to do things differently. And there's been so much good that's come out of this as well. And it's really been, although extremely stressful and challenging and, you know, emotionally draining at times, it's been fascinating to see how we've learned how to do this better and learn to understand this disease and rely on each other.
Absolutely. Danni, over to you.
Well, lots of things that I could say, but I will leave a very short closing remark, and that is just something that one of the anaesthetists said to me today. And it was an anaesthetist who worked on the ICU as a registrar, and I just occasionally see him in the hospital, and he's been redeployed recently as an ICU consultant to help, obviously, with intensive care when we expanded into the recovery. And I ran into him in the corridor, and he just said to me, "Oh my gosh, Danni, I have been so grateful for the dietitians recently." And I think he didn't just mean the dietitians. I think he really meant the whole MDT, because his point to me was that he was so completely focused on what he needed to do in this area that he was somewhat unfamiliar about. And he was so grateful to have a specialist there to take that away from him. Which I think is amazing. So we all have our specialty. Not one person can be responsible for every single aspect of that patient's care, and we can only do the best we can for the patient if we all work together. And I just thought that was amazing that he kind of picked that out, not because he said dietitian specifically, because I think he really meant the fact that there was, you know, the whole MDT there making his job a lot easier. So he had to focus on one thing, and we picked everything else up. And I think that that has been really what COVID has shown us, actually, the importance of all of the AHPs and the whole MDT working together, which I think has been amazing.
Excellent. Agreed. Penny, over to you.
So the same with the teamwork. Quite a few OTs, same as Danni was saying at the beginning, that OTs were pulled out of ICU, and there are some places around the country that OTs are still not in ICU. And wouldn't have let that happen, but I wasn't forced to try and fight my corner. But it's made a real big difference having the OTs there and the ability to have the teamwork. And one of the things that happened this week was one of the nurses just asked if I would help to help clean somebody, and I am totally happy to do that, and would always say yes, but the nurses don't always ask. And the fact that we've been kind of much more blending our roles means everybody's much more happy to ask each other to do things, and I can see someone rolling and how much they're responding and by doing that. So for me, that's a session. So it's really good to be able to work more as a team across the whole of critical care. And the only other thing I'd say is that in terms of fatigue and returning to work, I think there's going to be a pressure for people to return to work, and it's really important that people don't rush back to work. And I say that to any health professional listening as well. Like, take your time to get back to work, grade your return to work, because COVID is a killer for fatigue, and it can continue long term. So it's really important to take it seriously when you've been ill.
Thank you. And last but not least, Kate, do you have any final remarks?
A patient said to me this week that he's a musician, and he said, recovery feels like a symphony. I'm the conductor, but I need all of you to play your relevant parts. And I was pretty moved, and I thought, yep, he's got it. He's hit the nail on the head. So that's my final bit.
So just a final thank you to everyone, all the rehab legends here on this screen. If you are listening to this or watching this and you think, my goodness, we don't have the dietitian or the speechy or the OT, then just think about what would happen if this happened again. What would happen if your second surge come? Do you need to be looking at your workforce now? Do you need to be planning now? And let's learn from people today. And this isn't unique for these people here. This is happening across the country, and we're just so very grateful. So thank you very much, everyone.